Okay, well, thanks for having me here. And so if you have any questions or anything, just feel free to ask. I don't think that we should be terribly formal. So we're going to be talking about affective disorders in early life, adolescence, and also childhood, and some things about how that relates to what happens to people later on, and things that predispose people towards trouble. And so we'll be talking about several aspects of this, some of which go a little bit beyond the formal diagnostic mood disorders categories. But the thing that has always interested us about this is that there's two kinds of processes that regulate behavior that interact. And one is things that work over long periods of time. And the one we're going to talk about is just behavioral sensitization, especially to stressors. Some people are more susceptible to this than others, as we'll be discussing. And this, interestingly enough, this long-term process is strongly related to the immediate regulation of behavior, or the lack of it, that leads to impulsive behavior and other problems that are very prominent in bipolar disorder. So we're going to be talking about this kind of interaction between short and long-term processes and their kind of practical consequences. And this, as you can see from the little box there, it's this interaction is, I think it's important in normal life, but in terms of illnesses, it's important not only in bipolar disorder, but also in a lot of closely related problems, perhaps especially substance use disorders. This is what we're going to talk about. First, I see that if I look to the left, there's an unpleasant high-pitched sound. So I will try not to do that. I'll look at this thing. But anyway, first we're going to talk about sensitization, which is persistent effects of exposure to certain types of stimuli. And then we're going to talk about resilience, because sensitization clearly has been developed over zillions of years, because you see it not only in humans, you even see it in invertebrates. And it's a way of reacting to extremely salient stimuli. And where extremely salient things can have long-term effects on behavior. Sometimes that's not so good, and sometimes it is. And so it interacts with something called resilience that we'll be talking about. And then characteristics of mood disorders, and particularly characteristics of mood disorders early in life that sometimes can make it harder than one would expect to identify them. Because, children aren't just little adults, and even teenagers aren't. Then we'll talk about impulsivity, which is the other part of the short and long-term behavior business, and then some things about practical consequences and treatment and so forth. So behavioral sensitization is one of three ways that you can react to stressors. And so this slide shows that. So there's three things. One is that the stressor can be something that is inescapable and that is extremely disruptive and perhaps even terrifying. And that can lead to things like stress-related disorders like PTSD. It can worsen the course or accelerate the process of addictions or mood disorders. And there's three individuals on this slide, and this one here is experiencing the kind of a stressor that you might expect to fall into this category, a sensitizing stressor. Inescapable, severe, disruptive, etc. Then there are stressors that are part of normal life that often occur with the onset of things like bipolar disorder, but they don't make the course worse. But there are things like if you're in your early teens, where bipolar disorder often starts, there are things like romantic rejection and things like that. So this is clearly an example. Either it has experienced it or will be. And then the third kind of stressor, or the third kind of response to stressors, is when it can be actively coped with and escaped from. And so she is an example of this. It's not to be taken lightly, but being able to turn an inescapable stressor into an escapable stressor through active coping is, that's kind of what underlies that kind of cutesy expression, what doesn't kill me just makes me stronger. And so in her case, she'll be a faster runner and she'll be better at choosing her friends. At least I hope so for her sake. And you can see from the stuff that's written on the slide that severe stressors early in life have all sorts of bad clinical effects later on. So one interesting thing about behavioral sensitization is that it illustrates the way that the brain has very highly overlapping responses to things that are awful and things that you would think would be real good. And so the brain reacts similarly to addictive stimuli and highly rewarding stimuli to the way it reacts to inescapable stressors. And they produce sensitization, which cross-reacts. And so stressors that produce stress sensitization make humans and animals, where this has been studied a lot, more susceptible to addictions. And exposure to addictive stimuli distort the reactions to stressors. And so you have this interesting interaction, and I think that's because of this thing about saliency. Highly rewarding stimuli and highly stressful situations are both things where the brain basically has to say, man, this is a big deal. I need to be ready for this. And so the response to these things is enhanced. But I think partly perhaps because of the way we live, who knows, this enhancement is sometimes not useful. So increased all kinds of effects to, in humans, this has been studied mostly with stimulants, and also in terms of just retrospectively looking at what happens to people, it's been studied with a lot of stuff. It's also been studied, as I said, in animals going all the way back to invertebrates. And there's cross-sensitization across all manner of highly rewarding or highly stressful types of stimuli. Interestingly enough, if you look at things like a couple of groups studied development of sensitization to amphetamines in humans, and it was sensitization to rewarding effects and things like that. And I hope that the effects of the experiment were not permanent in these people's lives, but I think it'd be hard to get that through an IRB now. But anyway, what they found was that people who were impulsive, according to rating scales for impulsivity and things like that, people who were impulsive were more likely to be sensitized to these kinds of things than people who were not. And that's also been shown in animals. So there's an interesting interaction between impulsivity and sensitization, and the brain pathways that have to be stimulated in order to produce behavioral sensitization are analogous to the brain pathways that can produce impulsive behavior. So I've spent all this time kind of going over how these processes can interact because I think it has so much to do with people's lives. When somebody or some creature is sensitized to stressors and then faces a stressor, part of what they experience is stress-induced anhedonia, for example. And what could be worse for increasing suicide risk than stress-induced anhedonia, where stress makes you not feel like life is worth living? Basically, there are things that can make this sort of trouble more likely that happen in people's lives, which the slide lists: overstimulation, stress, adversity, sleep deprivation, addictive stimuli. All of those things get bad when somebody has experienced these sensitizing things during the past. I guess the place where you see that the most clearly is in people who have trauma-related illnesses like PTSD. So what you wind up with is increased impulsivity and activation combined with feeling bad and anhedonia. And that combination of essentially depression and activation is one of the most dangerous things you can have, especially so far as producing risk for suicide. So in normal humans, it's been done over a short term. One person studied things over a period of weeks, in which they got 3 doses of amphetamine. Either they got 3 doses of amphetamine, or 2 of placebo and 1 of amphetamine, or 3 of placebo. And what they found out was that the people with the third who got amphetamine all 3 times had a much larger response than the people who hadn't beforehand, and the spacing was such that the amphetamine was long gone from their systems when they were studied. And then somebody else did the same thing over a period of a year when they did PET scanning to study dopamine receptor occupancy. And so they kind of demonstrated it in that way. And people were still sensitized a year after basically a couple of treatments of amphetamine. And so that and some things that we'll be talking about later make you realize how important exposure to the wrong things is at the wrong time in somebody's life. So we'll skip this, but basically it shows, I'm not totally skipping it, but basically it shows that while we think about sensitization in terms of activating neurotransmitters like dopamine and norepinephrine, and the failure of regulating neurotransmitters like serotonin, also there's all kinds of other tantalizing things mixed up with it, especially inflammation, which is a very popular subject these days. So what's interesting to us, and what's implicit, in hope and healing, is resilience. So having talked about sensitization a little bit, and the horrible things that can happen to people who are susceptible to exaggerated future responses to salient stimuli, luckily there are ways, perhaps, to counteract this. Resilience is kind of an interesting word. I think we all think we know what resilience means. Comes from a Latin word that means basically to snap back to what something was before. And I think most of us that work with human beings and behavior and stuff like that realize that actually, usually in real life, snapping back to what things were like before is not necessarily enough. You have to be able to recover from what happened, but then, something has to be learned or something has to be gained. But resilience is, in some way or another, I think we'd see as the ability to respond in a positive way to a stressor and not be overwhelmed by it. But I think everybody in this room, each of us has our own definition of what that is. But I think most of us would say it's good. So it's strongly related to the same mechanisms that produce sensitization. And in some ways, it's sort of anti-sensitization. You need sensitization to some extent because it's useful to learn exaggerated responses to things that are very good or very bad, but unfortunately, that gets beyond the point of usefulness. So we're going to talk about ways how early stressors produce sensitization and some mechanisms for resilience. So it turns out that the stressors that produce sensitization are inescapable stressors. And this has been shown a lot with animals where you can do something, you can basically take a pair of rats, you can separate them so they can't smell each other, and so that they can't hear the high-pitched noises that rats make that we can't hear. And you give them foot shocks. And one rat is trained to stop the foot shocks by pressing a lever. And the other rat is not trained to do that, but it gets the same amount of shock as the rat that was able to press the lever and stop the shocks. All kinds of bad things happen to the rat who just is passively having the shock stopping. And all these things that we associate with bad effects of stress basically don't happen to the rat who is able to push the lever to make the shocking stop. So I think that very, graphically you can kind of see how that's related to the importance of developing active approaches to stressors, and also to reframing stressors in a way that they can be formulated as being basically manageable or escapable rather than inescapable and inevitable, and that even unsuccessful active coping is infinitely better than a lack of active coping. So one thing that when I first read this stuff really impressed me was the effect of prenatal events. And this has been studied in animals, and it's also been studied in humans, studying the offspring of women who were pregnant during war or similar really awful times. And the two groups of studies, very different in terms of their methods, produce parallel effects, which is that if you subject a mother rat to inescapable stress while she is pregnant, and then you look at the young rats after they're born, after they're mature enough where you can measure their behavior and stuff, they have exaggerated responses to drugs, and they have distorted responses to stressors, sort of a learned helplessness type thing. So that tells you that if you're exposed to these things in utero, either stressors or addictive stimuli, then you are at risk to experience sensitization to them after you're born and start getting mature. As if that wasn't bad enough, your offspring still have that susceptibility. Not as much as yours, but they do. And that's typical of a type of phenomenon called epigenetics, where a change is not made directly to the DNA sequence, but it's made to the regulation of how different genes are expressed or not expressed. And it turns out that that's a very important way that behavior can be adjusted and adapted to on the fly. But these important environmental effects and the way that they're transmitted to one or two generations should make us think a little bit about communities, and for that matter, about school. So there are ways that this can be prevented. One of them is by learning to reframe stressors. If the mother rat is exposed to the same amount of foot shock, but she is able to control it, the offspring don't grow up like that. Similarly, there's types of therapy that can apparently be used to help people who undergo stressors while they're pregnant. And then, of course, there's the situation that we think of drugs and chemicals and stuff as being bad during pregnancy because they can cause fetal malformations or because they can cause the mother to have unhealthy habits. But they're also problematic because they can change the brains of the developing fetus. These are all things we need to think about. So first, the stressor can be reframed. And the second is something that we'll be talking about called stress inoculation, which is what it sounds like it is. So anyway, prenatal addictive drugs. The more you read this stuff, the worse it gets. So on this, so the effects are similar to inescapable stressors. The thing that got me the most, and I'm still, is that and this is more than one group that did this, they took mice and they exposed them to binge alcohol when they were adolescents. Then, no more alcohol. And when the rats got a little older and they were mature enough to reproduce, they were mated and they had litters. And the little rats, even though they had not been exposed to alcohol during their development, the little rats appeared to be sensitized. And this persisted. And so, this it's the sort of thing that makes you think, and how are we going to take this great big inescapable stressor that this kind of, finding, sort of clobbers us with and make it escapable somehow. So what can we do about this? And don't worry, we're sort of meandering in the direction of actual mood disorders and their treatment now. But what do we do about this? So first, stress reframing, and I've already mentioned this about the yoke stress experiments in animals, and of course there the animal is not, you can't, teach a rat to reframe something, but you can compare what happens whether the rat can control it or not, and it makes a very large difference. Then something called stress inoculation. And stress inoculation is what the name implies. It seems that exposure to stressors that are manageable increases the ability to adapt successfully to stressors that would have not been manageable. Of course, people are very interested in this in military training and learning how to do stressful activities and all kinds of stuff. And if you look at the literature about it, it's a little mixed in terms of how effective it is. It really seems to be most effective when you're looking at reactions to stressors in general and not trying to use it to train somebody for a specific kind of stressor. But the idea of stress inoculation, one thing that it makes us realize is that if life is too perfect, that might not be such a good thing. That, it's the old, that which doesn't kill me just makes me stronger again. That being able to learn mastery of problems is part of being healthy. Stress inoculation, and I think also it's related to a lot of other things that are adaptive. So one thing which was studied a lot in animals is enriched environments, where you take a young rat and you let it live in a place where there's toys for it to play with, where there's more variety in its food, things like that. And that helps. That's almost like having stress inoculation. It helps the animal to adapt better later, and that's been studied some in humans. And that may interact with stress inoculation because of the fact that you're having that in an enriched environment, you're having challenges, and you're having variety of stimuli and so forth, and that sort of thing is apparently helpful. You apparently need that. I guess it isn't rocket science that you do, but for some reason there's been a lot of work done on this, and I think there's this lingering notion that we see in a lot of circles that somehow some sort of perfect life without stress is a good way to grow up. And the more I see this stuff, the more I think it isn't. So there's enriched environments. There's exercise, which also helps independently of everything else. It has effects on brain flexibility and production of neurotrophic factors, and neurotrophic just means something that helps nerves be able to adapt or regenerate or grow new nerve endings and stuff. And that's been shown, of course. We know it helps for depression. We know it helps for addictive disorders. We know that it probably helps for anxiety, and it helps for reactions to stressors. So exercise. There are medicines that may help. This needs a lot of work. The medicines that we use to treat people who have disorders that involve sensitization, motivation, and impulsivity, like mood disorders, tend to be aimed at trying to make the mood symptoms better. And I think that we need to aim them more at things that try to make these adaptive processes better, and things that can be complementary to the first four things on the slide. And the other thing that everything else on the slide kind of makes you think about is, and so when you see about these things like the bad potential consequences of inescapable stressors if they occur early in life or during gestation, for example, the importance of a varied, enriched environment, the importance of being able to learn how to adapt by exposure to stressors, shows the importance of a certain kind of community. Yeah. And you can see that there's probably some overlap among these things, because when exercise is helpful, you're doing enough exercise to be some kind of a physical challenge to your body, but you're not doing so much exercise that it totally exhausts you or causes you to have injuries, for example. Too little is better than too much. So, terms of mood disorders. Okay, so we can't see, and so I'm just going to, so I'll just take that into account. Thanks for telling me. So, when you look at kids who are at high risk to have mood disorders because their parents do, or if you look at, retroactively at what people seem to have been like, who as adults we know to have a mood disorder, we can see some things about characteristics. One of them is that before you could look at the kid and say, this kid has bipolar disorder because this kid has, 3 from column A and 2 from column B depressive symptoms for at least 7 days and whatnot, which kids don't do. But they're anxious. And they particularly have a lot of obsessive-compulsive type characteristics. A friend of mine, who's interested in this, as she went to various places around the country, developed this trail of families full of people with bipolar disorder that she was following. And possibly the most common problem in the kids was basically obsessive-compulsive disorder. And we thought that basically, sometimes when you have, so-called OCD symptoms, that could be your brain trying to make order out of chaos. That's probably why some people who have obsessive-compulsive disorder and a bad prognosis is a subgroup who are schizotypal. And you can see that basically their brain is probably trying to hold things together so that they don't become psychotic. So those problems are very prominent. And the obsessive-compulsive, possibly because of an attempted compensation, the anxiety and behavioral problems because of poor impulse control, not usually organized cleanly into depressive and manic episodes the way we picture these illnesses, because in school we learn about the way they're seen in adults and not kids. The symptoms are different. Now, you do see hypersexuality in 8-year-olds, but not enough where you can say that it's a typical symptom of mania in an 8-year-old. For that matter, grandiosity. If I started walking around telling people that I was going to be the first man on Mars and that I had this big plan that I was going to do it, I'd probably get locked up. On the other hand, just about every 8-year-old kid goes through that at some point, something like that, and that's normal. On the other hand, the kid can express grandiosity in a way that it is grandiosity compared to the behavior of kids. Like sitting down in the principal's chair and saying, I can run the school better than you can, or something like that. Impulsivity is very prominent. Of course, it's more prominent in kids anyway. It starts out being somewhat increased. It increases more as you become an adolescent because you've got more ways to express it. And then, when you get into your early 20s, if you're lucky, your prefrontal cortex, which is part of your brain that's involved in kind of reflection and behavioral adaptation and inhibition, matures. And so in your early 20s, things begin to change. Some people earlier, some people later. But the process always is that behavioral activation develops first, and behavioral inhibition develops later. Which is why, of course, kids have all these reflexes when they're infants, and they lose them when they get older unless there's something wrong with their brains. So activation develops first, and so impulsivity is a problem. And it's kind of interesting if you look at major depressive disorder and bipolar disorder, and you look at people whose parents had these disorders, who are at high, people say genetic, but nobody knows anything much about the genetics of these disorders really, except that they run in families. And so I'll say high familial risk. The ones who are at high risk, but who don't have any of the symptoms of the mood disorder yet, are already more impulsive. If you use standard impulsivity scales to measure that. There's some very basic relationship between impulsiveness, along with sensitization, and the risk of mood disorders. In terms of what kind of mood disorder someone's going to have, of course, there's a lot of argument about whether bipolar disorder and major depressive disorder are actually different illnesses or not. But assuming that they are, 2/3 of people, maybe more, with bipolar disorder start out with depression. But our diagnostic criteria for bipolar disorder say that you have to have been manic or hypomanic. And so if you say that bipolar disorder is different, but these 2/3 of them are going to start with depression, and years may go by before they have their first manic episode. So that's not a very good test for bipolar disorder, is it? There must be a better one. There are some predictors looking at kids that have depression or who have the kind of disturbances that I mentioned earlier. One is a family history of bipolar disorder as opposed to major depressive illness. Although the commonest mood disorder in the families of people with bipolar disorder is major depressive illness, and so you got to be careful about that one. Another is that the problems that they have are more unstable and more frequent, usually, if they're going to have bipolar disorder compared to major depressive illness. And so that helps a little bit. Coexisting problems, like attention deficit disorder, which can coexist with mood disorders, especially bipolar disorder, or obsessive compulsive disorder, things like that, more common in kids that are going to have bipolar disorder than kids who are going to have major depressive illness. And then, something that's not on the slide, but that has to do with treatment. And that is that people with bipolar disorder don't do so well necessarily with antidepressants. And this wasn't kids, but this was looking at people in a large, population that was part of one of these big healthcare plans in the West, looking at who had a diagnosis of major depressive disorder and the diagnosis switched to bipolar disorder. And in these big files of data, you don't really have that much which is useful. But one thing that you have is what medicines they were getting and how often the medicine switched and what the diagnosis was in the chart and whether it changed. And so it turned out that after you correct for age and how long they'd been in the system and all that stuff, that people who converted is in quotes, because if bipolar and major depressive disorder are different, they always had one or the other, but people whose diagnosis changed were people who had had at least 3 different antidepressants. So not responding to antidepressants was, in that kind of blunt instruments, the best thing to pick up. And you see that some in kids, although usually in kids there hasn't been time to have 3 antidepressants. Impulsivity and conduct disorder, diagnosis and things like that are more common in people who are going to have bipolar disorder. But so each of these, OCD, attention deficit disorder, impulsivity problems, family history, none of those things is perfect. That all these characteristics, you're going to have people that are going to grow up to have major depressive disorder who have those characteristics. It's just that bipolar disorder maybe gives you 30, 40, 50% higher. And there's another catch, and that is that a certain number of kids that have these kind of problems are going to grow up to look pretty normal. That somehow some of them, I guess, their prefrontal cortex is able to develop and filter all this stuff out. And others will go on to have a mood disorder that may get increasingly severe. And it would be really nice if there was some way that we could look at kids that had these behavior problems, and in the absence of something really extreme, like a family history that's just full of bipolar disorder and trouble. So, look at kids where it isn't so obvious and say, who is likely to grow out of this and who is likely to need lifelong treatment? Because some of the strategies that you use are going to be the same in terms of helping them to manage their behavior and manage stressors and things like that, but some are going to be different. So the next slide talks about what impulsivity is. And normally, we have a way of filtering, an ongoing way of filtering stimuli and potential action. And basically, there are two factors that compete in this. One is activation. I'm going to do it. And the other is inhibition. No, I'm not. And there's usually some kind of balance. And we usually have, after a stimulus, as Dr. Stanford has done a lot of good work about this, after a stimulus, your brain has a few hundred milliseconds during which you are not completely aware of the stimulus, but your brain is going to make a first cut decision whether to throw it out, whatever it was, forget about it, or whether perhaps to go ahead with it. And then you're going to have a chance to decide whether you're going to do it or not. Does that make sense? I hope. So the problem that happens when somebody is impulsive is that doesn't happen, that balance between the initiation of action and the inhibition of action is out of whack. And so you don't get to scratch your head for a little bit. Something happens, and you don't really get to think about it first. And that kind of behavior where decision-making doesn't really get to play a role is what impulsivity is. So conscious deliberation and choice, which is normally part of even simple behaviors, is gone to the extent that behavior is impulsive. Nobody is impulsive all the time, and nobody is never impulsive. But there's a threshold, where it becomes a problem. And likewise, you can argue that many behaviors have sort of a component of impulsivity and a component of premeditation. But this ultimate ability to make a decision about an action and be aware before you do something that you are going to do it is the hallmark of what is and isn't impulsivity. And so there's two ways that impulsivity is expressed. One is over long times, and that's trait-related impulsivity, like the Barrett Impulsiveness Scale. It's an amazing instrument, actually. It's been around for a long time. If you look at it, much of the phrasing in it no longer makes sense to most of the people to whom the scale is given. It's given to kids. It's never been it's never really been validated in children, and many of the questions you would not expect to make sense to children. But there is something about this scale that really picks up impulsivity. It is a very robust instrument, and someday somebody will come up with something better, but I don't know of anybody who has. So that measures your propensity towards impulsive behavior, but it doesn't, maybe that made it shut up. that measures the propensity towards impulsive behavior, but it is not a measure of actual impulsive behavior and impulsive responses. And those state-related impulsivity measures can be measured by various computer tasks or neurophysiology. And it was interesting, Ernie Barrett, who Dr. Stanford and I at least knew for decades, would always get into arguments. He said there's no such thing as state-dependent impulsivity. You know, you're impulsive or you aren't. He would, you know, and so we finally had a peace treaty, and so he said, okay, we're not talking about state-dependent impulsivity. We're talking about whether trait impulsivity is expressed or not. And that made him happy. Or at least he said it did. So there are things that can make impulsive behavior more likely at a given moment, which is clinically in some ways and in real life what we need to be interested in. And they're basically, you know, one thing that ties them all together is that they shut off inhibitory systems in the prefrontal cortex. They often do it through release of norepinephrine, but not always. So there are things like acute stressors, overstimulation, certain drugs, sleep deprivation. You can easily come up with a list of a dozen. And the likelihood of those things resulting in impulsive behavior becomes greater if your so-called trait impulsivity is higher. And it's greater in people who have experienced sensitization to stressors or to addictive stimuli. We found that in people with substance use disorders, people with bipolar disorder, people with both, people with so-called cluster B personality disorders like attention deficit disorder. One interesting thing about impulsivity is the way it interacts with hopelessness. So, and again, this comes straight from the Barrett impulsiveness scale, but we didn't pick it up at first. We looked at people who had made a potentially lethal suicide attempt, and they varied in how impulsive the attempt was. The people who made impulsive suicide attempts were not more depressed than people walking around on the street. They were not more depressed by the usual measures of depression. But according to a standard measure of hopelessness, they were just as hopeless as the people who made thoroughly premeditated suicide attempts. Well, the Barrett impulsiveness scale picks up on three characteristics. The first characteristic is inability to tolerate cognitive complexity, basically. Inability to look at a situation and say, what do I do now? Something is complicated or unexpected or anything like that, you throw your hands up in the air. That's it. You give up easy. Another, that's part of attentional impulsivity on the Barrett impulsiveness scale. Another aspect of impulsivity is what Dr. Barrett called non-planning impulsivity. You have no sense of the future. So you give up easy, and you have no sense of the future. That's hopelessness. And usually we think that in order to have those characteristics, somebody has to be depressed. All they have to be is impulsive. If they're depressed too, they are in a really precarious situation. So impulsivity and hopelessness interact. And the third facet of impulsivity in the Barrett impulsiveness scale is motor impulsivity, which is impetuousness. So you take giving up easy, not having a sense of the future, or of the past for that matter, and impetuousness, and you see what a treacherous situation that is. So that's why impulsivity is a big part of suicide. There's a slide here about suicide. I think that we might talk about suicide during kind of a discussion instead, but they just want to point out that suicide in children and young adults has been increasing over the last few years. And you can see that a lot of the potential mechanisms that could lead to resilience against suicide are not developed yet in kids. On the other hand, things that lead to poor behavioral control can pretty much take the lead. And so a kid who has experienced inescapable stressors, who's been exposed to addictive stimuli, who has a strong susceptibility to bipolar disorder, whose course is strongly marked by behavioral sensitization, those kids have a substantial risk of self-harm, and for some reason that's been going up. So the other thing I want to mention about suicide, impulsivity is woven through it. Suicide, the last year that there's data for was a couple of years ago. And I could ask you a question, but the thing is I've already given away the answer. If you compare suicide, homicide, and motor vehicle accidents, one of them is about 45,000 people died. This is in the U.S. Another one is about 30-odd thousand people died in the U.S. And the last one is maybe about 20,000 people died. Which one of those do you think is suicide? Of course, it's the big one. It's the 45,000. And more people, substantially more people die by suicide than by motor vehicle accidents. Lots more people die by suicide than homicide. And that's been increasing steadily since like the turn of the century. And suicide is increasing in all age groups, but in some ways the most alarming part is, of course, the younger age group. The more hopeless, that's the aspect of depression that's the most related to suicide. The more hopeless somebody is, the less impulsivity and activation it takes to be decisive in terms of suicidal behavior. The more impulsive and disinhibited somebody is, the less hopelessness it takes. And so you see there's kind of a spectrum of two things that have to combine, this activated depression type spectrum. The more activation you have, the less depression it takes. The more depression you have, the less activation it takes. If you're kids, you have both. And activation combined with depression is much more common in kids than it is in adults, where you start getting more kind of pure depressive states. So something we need to watch for, because it's not expressed the same. So in the course of bipolar disorder, they have increased trait impulsivity from the start, way more than even people with major depressive disorder. At first, the computer measures of immediate impulsiveness in people with bipolar disorder who are not having an episode of illness are normal. If somebody with bipolar disorder has childhood trauma, if they also have a substance use disorder, if they've had lots of episodes of a mood disorder, however, that's not the case. And even when somebody with bipolar disorder is not having an episode of illness, they already have this immediate susceptibility for impulsivity. And that is a very precarious way to go through life. And if your brain is working that way and there's nothing to help it work in some other way, you're not going to develop the ability to solve problems, the ability to relate to other people under complicated circumstances, and therefore provide yourself with a good support system which could otherwise save your life. You're not going to be able to do those things so well. So it's a scourge. Then in terms of, have two slides about the course of bipolar disorder. One of them is a sine wave. You've seen these. Here's depression, and here's mania, and here's depression, and here's mania. And the caption is wishful thinking. And the other one is a roller coaster, a really totally tangled up spaghetti-like roller coaster. And the caption is real life. And that's especially the case with kids and adolescents who have mood disorders, that they don't have this organized. Some do, but they are much less likely to have this organized, structured course of being depressed, manic, or stable. We can't depend on that. And some people with bipolar disorder go through their life, and sometimes they have manic episodes, and sometimes they have depressive episodes, and sometimes they're stable, and the episodes can be awful. But they have this basically episodic course with stability between episodes when they can build a life. Others don't have that. Their episodes may not be as severe, but they're never really stable. There's always something cooking there, and the episodes they have are frequent. And you ask them, how often have you felt after you talk about what we think depression or mania is? We ask, how many times has this happened to you? And on the one hand, people will say, well, let's see, there was last year, and then there was a couple of years ago, and so forth. On the other hand, these folks with the unstable course of illness will say, I don't know, I can't count them. And the earlier in your life bipolar disorder starts, the more likely it is that you're going to have this chronic, chaotic course of illness. So that's associated with early onset, whether that's because you inherited something really severe, whether it's because of something sensitizing that happened to you, whether there's probably some combination, who knows. So we have in treatment, we have some dilemmas and some goals in thinking about in children or adolescents, whether to use medicine, for example. And it's interesting just to balance off what they are and what our priorities are. It's similar to the dilemma that you have in terms of, what to do for kids that have attention deficit disorder, etc. So many medicines that are used to treat mood disorders have potential long-term side effects that are bad. They can cause renal failure if they're lithium. They can cause tardive dyskinesia and metabolic syndrome and start you off in life with poor health and being overweight if they're second-generation antipsychotics, etc. And perhaps they can interfere with some aspects of function having to do with flexibility or creativity and stuff. So I take a chance with these things. And then to make matters worse, a certain number of kids that have problems, to use kind of a glib term, are going to grow out of it. So I give somebody toxic medicine when they're going to grow out of it. On the other hand, some are going to need medicine if it works for the rest of their lives. So I think that a major player in this dilemma of finding treatments is that what happens to us during childhood and adolescence is irreplaceable. That's when we learn how to handle situations. That's when we learn how to interact with other people. That's when we develop curiosity, etc. And anything we can do to give a kid a chance to do that, we should probably try to do, because the kid is never going to get those years back, So a kid that because of his behavior can't stay in classes in school, that's going to hurt the kid for his whole life. And so to some extent with medicine, I say, let's help this person do what she has to do in order to be a child and an adolescent and grow up. And then as time goes on, do whatever we can do to kind of keep things healthy. There's this balance, there's this dilemma. And there's also a balance between pharmacological and non-pharmacological treatments. And I think a lot of the non-pharmacological treatments that I'd mentioned before are actually almost societal treatments as well as being treatments for an individual or for a small group. Things that assure, for example, things that minimize the exposure to addictive drugs in kids before they're born, for example. A system that provides folks during their education with the chance to learn how to reframe stressors and use them adaptively, and learning to value that. When you're in school, why not? Be able to use exercise as something that you incorporate and combine with your life, rather than something that you do just in order to be a star, etc. So, and then, of course, scientifically, one thing we need is some way to figure out early what's going on. So, a couple of kind of, paradoxes. First, the analogous brain responses to things that are highly stressful and things that are highly rewarding. The interaction between the long-term and the immediate regulation of behavior, and the fact that in order to be resilient and to develop normally, it's probably just about necessary to experience stressors. And so somehow I think these things go into the real life side of the development of kids who are susceptible to mood disorders. So I'd like to basically, the last slide is a cartoon that I like, and there's a fellow who's climbed to the top of the mountain, and there's this sage sitting there in front of a cave, and the cage is saying, why do you want to know the meaning of life? You can't do anything about it anyway. And of course, that ain't true.